Hello, thank you for joining the ERJ Podcast. My name is Dr. Don Sin. I'm the Deputy Chief Editor of the European Respiratory Journal. Today, I'm joined by Dr. Peter Gibson to discuss his latest paper entitled Distinct Trajectories of Treatment Response to mepolizumab toward Remission in Patients with Severe Eosinophilic Asthma. Dr. Gibson is a professor of medicine and public health at University of Newcastle in Australia. Dr. Gibson is an international leader in asthma phenotyping and treatment. He has published more than 750 journal articles and has received many awards for his groundbreaking research in asthma and its management. Hello, Peter. Many thanks for joining us today.
Hi, Don.
Could you provide a brief summary of your study and its main findings?
Sure. So this study looked at patients with severe eosinophilic asthma who received mepolizumab treatment, and we recorded their eligibility and their response as part of a registry, the Australian Mepolizumab Registry. Once the patients were enrolled, we followed them prospectively for a year and looked at how they responded to the treatment in terms of asthma control, exacerbations, lung function, and oral steroid use. And what we were particularly interested in looking at was to try and get a handle on the variability of response. Because as you said, some people respond extremely well, others not so well. And the way we did that was we used a statistical method called group-based multivariate trajectory modeling. It's basically looking at how the person responds over time and grouping those that follow a similar trajectory. And we found that the best model identified 3 different trajectories in response to treatment. 2 were really responsive. The patients that responded really well had less oral steroid or no oral steroid use and a marked reduction in exacerbations, compared to the 3rd group, which tended to be less responsive. Although they had a clinically significant response, but it wasn't as big or as sustained as the first 2 groups. And perhaps the really interesting finding was that the trajectory or how the person responded to mepolizumab was then associated with whether or not they went into remission. So about 1 in 4 went into remission in the first 2 groups, the good responders, whereas in the group with the poor response or the flat trajectory, only about 6% went into remission. So that's quite an interesting observation. I think clinicians recognize that patients vary in how they respond to treatments. It's been hard to measure that, and this methodology allows you to do that. And we saw these sort of clinically relevant groups with the important outcome of remission being different between groups.
That's very interesting. How did the patients get enrolled in this registry? What clinical criteria did they have to receive mepolizumab?
So there are about 20 centres throughout Australia, and our patients attending severe asthma clinics. They were either been in the clinics as long-term patients or they were newly referred from primary care. Then they were assessed by their respiratory or thoracic physicians, and then they had to meet some reimbursement criteria. Our government reimburses mepolizumab providing the person meets certain eligibility criteria. Those criteria are very similar to the phase 3 registration trials, but briefly, they have to have a confirmed diagnosis of asthma for at least 1 year. So have asthma for at least 1 year with objective evidence of variability. They have to have their asthma management skills optimized, so optimized inhaler technique, adherence, and be on high-dose treatment. So that's high-dose inhaled steroids and long-acting beta agonists, often with frequent exacerbations and also impaired lung function, FEV1 less than 80%. They had to have uncontrolled asthma despite all of that, and that was measured by the asthma control score, an ACQ. That had to be greater than 2, and they had to have evidence of eosinophilic or T2 inflammation, and that was from a full blood count, eosinophil count greater than 300 cells per microliter.
Does the registry require measurement of airway eosinophilic inflammation, such as with induced sputum or bronchoscopy or some other method?
It doesn't, and we don't have that information. It would be really interesting to know that, obviously. But I suppose the difference between this and a clinical trial is we try and minimize the data collection burden and capture patients in a real life setting in order to maximize the number of patients that can get in.
Okay. And you said there were 3 groups, and group 3 had the lowest response, perhaps only about 6% full clinical remission rate compared to 25 to 30% or more in the other 2 groups. Can we discuss a little more about this group 3? What kind of clinical characteristics or traits did they display? Were they different than group 1 and 2?
Yeah, that's an interesting question. And they're an interesting group because there are some things that you might expect to be different and some things that you would also think should be there but were not there. So they had more airflow obstruction and they also had a very long duration of asthma. So that you would sort of think that maybe they've had asthma for a long time, lots of exacerbations, and they're less responsive for those reasons. So in that way, they did differ from group, say, 2, trajectory 2, which were relatively recent onset. And that would be the typical late onset asthma, often with nasal polyps. However, they weren't more likely to be smokers in group 3. So you might think, oh, well, they're more likely to be smokers. That's why they're not responding. But that wasn't the case. And they were also predominantly female. In that way, they were similar to trajectory 1, which was a responsive group. They were also predominantly female. So I think the interesting thing about that is whilst airflow obstruction might be important, it's really you had to observe the patient's response to treatment in order to work out which group they're going to get into. And this has actually been observed in other diseases where they've looked at treatment response trajectories. So, for example, in rheumatoid arthritis, looking at anti-TNF responses, whilst you might be able to separate groups at baseline, that doesn't always predict their outcome or their treatment response, and you have to actually observe it in order to detect it. And that's important because I think that backs up what experienced clinicians see. They do see variation in response, and we often get surprised, often by how good people do, and sometimes by how not so well people do. And I think what this sort of work is telling us is that clinical observation is an important observation because it then relates to their future outcome on therapy.
Very good. If the patients did not respond to mepolizumab, say over a year, I think that was the duration of your follow-up, do you have any information as to whether they went on a different anti-IL-5 therapy or perhaps an anti-IL-4/13 strategy or something else? What happens to these patients who don't respond as well as they ought to?
That's right. They don't respond as well. So the first thing to say is what you're describing is if we just say we set up remission as our goal, and if we're focusing on this group 3 because hardly anyone went into remission. If we were to say, okay, we want to treat patients to reach the target of remission, that's a different paradigm than what we're doing at the moment. That's treat to target. That is an established paradigm in some diseases such as rheumatoid. It's not yet established in the asthma field. And what's one of the important things about this study is that it allows you to start a conversation about treat to target using some data. Just getting back to what actually happened to the patients. So to continue to receive government subsidized mepolizumab, the person has to demonstrate a clinical response every 6 months. And that clinical response is based on the asthma control score. So they have to keep achieving a clinically significant improvement in asthma control compared to their baseline in order to keep receiving the drug. Most of the people in the study do that. So at least 80 to 90% still show an ACQ improvement of 0.5 or more. But within that, you can see there's variation in how big a response they get. And then those that didn't achieve that or kept having exacerbations, they would have been swapped to another drug.
I see. And do you have similar registries for the other anti-IL-5 therapies or dupilumab?
The Thoracic Society of Australia and New Zealand manages a registry for benralizumab and for dupilumab. Before we started this registry, we had one for omalizumab, but that was closed because of lack of funding and the end of the study.
I see. What should the practicing clinicians take away from the findings from the current study?
What I would say is to recognize and trust the variation in response. Trust your clinical observations when you see variation in response, and then start thinking about, okay, if the person's not responding so well, what else might be going on? What can you look for to try and explain or achieve a better response? Secondly, to be confident that it's now possible to quantify and measure this clinical variation in treatment response. And thirdly, what I would say is watch this space, because I think many people are thinking, okay, can we do better with asthma remission? Can we get it better than 1 in 3 patients? It's such an important outcome for patients if they achieve remission that many people are wanting to aspire to get more patients into remission. If we were to continue the way we are now, we'll get about 30% into remission. But what this study tells us is that you can start to separate people out and perhaps ask the question, okay, can we pick this earlier than 12 months? So for example, at 6 months or 3 months. And at that point, would you want to change treatment or look for other reasons for non-response?
So do you think a remission rate of greater than 30% is possible, or do you think this is sort of the limit?
I don't think it's the limit for 2 reasons. We did a similar analysis. We did a large RCT of azithromycin for moderate to severe asthma that was uncontrolled on ICS-LABA. And we saw a higher remission rate in that population. So it was about 50% plus. So I think it's plausible that we can go above 30% in severe asthma. The question then is, okay, how would you get there? And these are proposals or ideas that need to be tested in trials. But one that's getting a lot of attention is earlier introduction. So if you notice the trajectory 3 had asthma for many, many years, is it possible if you intervened earlier, you might have got a better response? That was the case with trajectory 2, for example. What are the reasons or what are the traits that are stopping people going into remission? So there are some other things that are going on, we think. So like high BMI, depression, other diseases, BCD, ILO, things that might mimic or contribute to severe asthma that could be treated differently. They are proposals or they're ideas that give us hope that there might be ways to increase the remission rate, and we should test those out with new tools.
Well, asthma treatment has come a long way, but there is room for significant improvement. I think that's your message to the audience. So there is great hope for the future for even better therapies, better management strategies on the horizon.
Yeah, that's for sure.
Well, maybe on that very positive note, we'll close our podcast. And thank you for joining us today. Dr. Gibson's paper can be found on the ERJ website in January issue of the ERJ. Thank you.